All right, so I wanted to take some time to talk about efforts, not necessarily just at Duke, but really efforts we can all be making to build capacity to address mental health and juvenile myositis. So, just as very brief background, there is now a pretty substantial literature on high rates of depression, anxiety, suicidal ideation, really well described in juvenile idiopathic arthritis and childhood onset systemic lupus. And even so, even though we kind of know about this from the academic literature, in our clinical practice, we find that in these patient populations, these mental health comorbidities are under-recognized and undertreated. Um, and so one of the things that's really concerning from a JM standpoint is that although it's also well established that JM patients typically have worse psychosocial health related quality of life compared to control patients who do not have JM, there has not until recently been a lot of scholarly literature on the mental health impact per se of our JDM patients. And so I wanted to give a little bit of background on efforts to kind of increase that knowledge base and things that we can do to address this pressing need. So one of the early efforts, and this was supported by the foundation, so really must give gratitude to Cure Jam for catalyzing this, was the focus group study that we did for to assess, parent perspectives on the emotional health impact of JM. And this is kind of the key figure that ties together all the themes that came out of those focus groups, which were done at one of the Cure JM Foundation annual family conferences. So, briefly, the impact of living with JM, both the symptoms of JM itself as well as the toxicity of existing treatments, is tremendous. And families spoke in great detail about how the impact is not just on the child or the patient themselves, but there's kind of a ripple effect through the whole family. The parents' emotional health is impacted, and siblings and other extended family members' emotional health, as well as their dynamics in the family between all these individuals, are affected. And so really taking that kind of whole family perspective is going to be important for comprehensive care of our patients. Another theme that came up was that, particularly in the young adult focus groups, parents of young adult focus groups, there was the emergence of resiliency over time, that our patients do sometimes seem to learn about the importance of maintaining hope, of developing a sense of altruism towards others, of developing competence around their day-to-day affairs, that maybe those who haven't been through the challenges of JM might take longer in their life to develop, but that resiliency can kind of backslide into distress if and when low disease activity state goes back to a high disease activity state. So this is dynamic. And, the other thing that we talked about in these focus groups was how can we help? How can we help detect these needs, and how can we address them better? And over, one of the most important themes that came up is that parents felt, and they felt that their children would say this as well, that pediatric rheumatologists play the key role in eliciting mental health needs and referring patients to care. Sometimes there are debates in pediatric subspecialty communities about whether this is really the purview of the subspecialist. And it seems like whatever we might think about this is something that parents and patients want. And this replicates findings from an earlier partners survey study as well. Families also told us that they felt a dedicated screening protocol is needed, because just doing routine history taking may miss some of the mental health challenges that their child might be going through. And then access barriers are a huge challenge. So even for those families who recognize the need for mental health evaluation for their children, these were very savvy families, and yet still they found it very difficult to get appropriate mental health evaluation and treatment for their children, especially the type that would take into account the chronic illness component. So along those lines, families are open to novel modalities that might overcome these, whether technologically mediated or otherwise. So that was an important initial study, and then we were able to get CARA grant funding to work with our partners, So here at Duke, we were able to work with our partners at Hospital for Sick Children in Toronto and Seattle Children's Hospital to do what is the first multi-center mental health screening study in JM specialty clinics. And We're working on submitting this manuscript in hopefully the weeks to come, but we've presented a couple of abstracts with the preliminary analyses, and what we found is that, first of all, mental health screening is feasible and acceptable. So, there was greater than 90% completion of each patient and parent screener that we administered, and we administered up to three patient screeners and up to two parent screeners, depending on the age of the patient. The vast majority of patients and parents had basically minimal, if any, difficulty completing these screeners. And then almost all patients and parents felt that routine mental health screening is indicated at least annually, and many more felt that it should be more frequent. When we did this screening, we found that about 68% of patients across the three sites had at least one positive screening result across the various screeners that were administered. And although we couldn't in this study follow up and see if, what proportion of those patients had formal DSM diagnoses of depression or anxiety or things like that, nevertheless, we were able to administer PROMIS emotional health measures that we found were significantly worse in the screen positive group, indicating that there is a real difference these screeners are picking up. And again, challenges remain. So we surveyed parents typically about 4 weeks after the screening, 4 to 8 weeks after screening, and found that 3/4 of those who responded to that survey could not arrange evaluation for their child within that time frame after positive screening. And over half of parents felt that there are ongoing unmet mental health needs for their patients. And this is at three specialty sites, COEs and so on. So it just indicates the magnitude of what we need to work with. So again, there are other studies beyond JDM literature that indicate over and over that patients and families see us as having the central role in evaluating mental health. But even though most CARA survey respondents in a prior study by Andrea Knight and her colleagues endorsed the importance of the screening, the actual rate of routine mental health screening with validated screeners is vanishingly low. And it's important for us to address this because we cannot uncouple mental health from physical health. So in some of the preliminary data from both the mental health screening study that I mentioned earlier, as well as the LEAD CV cohort study that I just finished up that Andrew mentioned, where we were looking at stress and cardiovascular health risk, there are some indications in the data that mobility and other disease outcomes may be worse when mental health comorbidities might exist, and certain health behaviors like medication adherence, diet, physical activity may be worse as well in association with worse mental health. So mental health is physical health is what I would submit. So that's to kind of catch up on, kind of the state of our knowledge about the impact. And again, thanks to the foundation for really jump-starting a lot of this work. I wanted to talk about things that might be able to help address some of this. And so I'll spend most of my time in the next few slides talking about the American Board of Pediatrics Roadmap for Emotional Health, which is really a national effort meant to help providers in various pediatric subspecialties to initiate more mental health conversations with their patients and families in routine care, begin implementing formal mental health screening procedures, deepen the local partnerships between, say, pediatric rheumatology and allied professionals like social workers and med psych specialists who can help us address the mental health needs of our patients, and then collating resources, whether they're local and state, institutional, CureJM, and other foundation type resources. Sorry, that's showing up twice on this slide because we're participating in this ABP roadmap and as part of that, doing some of that collation. The other thing that I'll just highlight, but may not be talking about quite as much just due to lack of time, is that Suzanne Edison in particular has been just a galvanizing force in gathering a lot of us together, whether in the CARA mental health work group or those of us who are specifically focused on patients with JM, to try and develop and administer trainings on mental health screening and other mental health related topics. So Tala Altal in Toronto had put together these mosaic of mental health workshops that some of us have gotten to participate in and present at. At the most recent ACR Convergence meeting, there was an outstanding 2-hour workshop that we were able to put together and we're hoping for 2024 to if ACR is willing to present on both pharmacological and non-pharmacological first-line management strategies. So things to keep your eyes out for, even though I may not be talking about those in detail today. So the ABP roadmap, as I mentioned, is this kind of national sort of attempt to use QI methods to improve kind of the standard of care for mental health in pediatric subspecialties. And I'll walk you through kind of the workflow that is proposed by the ABP roadmap leaders. So the first step is really to raise awareness of this problem. So some of the data I presented earlier, one could say might fit with that mission, which is really to kind of understand the prevalence of mental health comorbidities in your patient population, share back to folks in your own division or institution about stories that highlight challenges that are occurring for your patients in light of the mental health needs that they have, and then starting to gather teams together that can begin ideating like how to best approach addressing these issues and what barriers might exist that make it hard to address these issues. After that, the next stage is to begin identifying resources. So, developing lists of resources, again, locally, institutionally, and beyond, that can help your patients either connect with therapists, connect with other psychosocial supports, and then also developing crisis plans in case you identify mental health emergencies in your routine clinical practice. So, a couple of the things that we've been working on locally that I can talk about. So, one is that we've had over the last couple of months meetings with our social workers to try to update a robust resource list with their disciplinary input combined with our input as pediatric rheumatologists, so that we can develop dot phrases that can be used in our routine clinic setting to provide like lists of resources easily to our patients and their families. And then thinking about a broader range of resources than, for example, just, referrals to therapists and things like that. So thinking about, what available peer support programs exists, other programming via advocacy organizations like CureJM. School and college-based supports, I think, are really underrated. I in particular have a patient who found it really helpful, both from a confidentiality standpoint as well as just from a kind of understanding the context of their life standpoint, to access mental health resources through their university system. Increasingly, there are apps that are readily available that may support mental health and increase access to therapy across geographic boundaries. And then thinking about mental health in broader than just biomedical, context. So spiritual care, other self-care resources that might be meaningful for our patients' mental health. There are state and national resources. North Carolina has a phone line called NC PAL that you can actually dial and discuss with the mental health provider what is going on with your patient, whether that's a positive screening result or information they're sharing with you that suggests that they may be dealing with depression, anxiety. And through this line, you can actually get oftentimes expedited mental health evaluation for your patient. And sometimes the operator on the PAL line, or the respondent, excuse me, on the PAL line can walk you through some initial psychopharmacology if you're comfortable with that, and coaching on like brief CBT or things like that. My understanding is that many other states might have these types of PAL lines. So something to look into, particularly if local access to mental health is a challenge at your site or for your patients in their community. There's 988, which is the U.S. Suicide and Crisis Lifeline. And then for families, finding a therapist can be challenging, but there are websites like Psychology Today or Psychologist Locator, which can help families identify sort of lists of mental health providers that can be filtered by like whether they see patients that are the right age or concordant with various identity factors that are important, whether that's race, ethnicity, gender identity, sexuality, things like that. So, all right. So the next stage, sorry, there's like a sort of a banner in the way. Okay. The next stage is kind of developing knowledge and confidence. So this is really about actually being able to have the conversations and respond in real time to what you learn from your patients and their families when you discuss mental health. So I think it's really underrated thinking about the importance of just initiating these discussions, even way before you have any sort of screening procedures in place. So we've heard a lot of times really profound stories from patients and parents about the value of just asking, "How are you doing?" Like just pausing for a moment from all the biomedical topics that we have to address, and just asking patients or asking their parents, like, "How is this going for you? How has this been?" And trying to do that, either at or soon after diagnosis, but then at visits thereafter, because there is this dynamic way in which the mental health impact of living with this condition keeps changing. And then a methodology for approaching these mental health discussions in a systematic way that's proposed by the ABP roadmap is this normalize, ask, pause, connect. So the idea would be that when you want to broach the topic of mental health with your patient or their family, to first just normalize, in other words, to address head on the fact that people might feel stigmatized and might feel uncomfortable talking about this, and so we can open up by just noting that we know, and we find when we talk to our patients and their families, that mental health concerns are very prevalent. I mean, I would almost argue universal on some level. And so that the idea there is that, our patients and their families that we're meeting with in that moment, they're not alone. This isn't unique to them. Then just asking brief open-ended questions about emotional well-being and distress. So, this can be really hard to be on high-dose steroids. Like a lot of young people will tell me that they find that might be a difficult experience. How has it been for you? Sort of questions along those lines. Then pausing, because it may be the case that patients or their parents or other family members might have never had these kind of questions asked before in a clinical encounter, or may have been dealing with so much else that they just haven't even had a chance to really sit down and process, what am I feeling? What are we feeling? So taking a moment to pause and create an open silence into which folks can respond when they're ready. And then based on what you learn, connecting patients and family members to support and resources, and thinking not only about the distress or the deficits or the challenges, but also leveraging patient and family strengths, because typically there are some that we can identify during these conversations. And I would submit also considering a preventive mental health approach. So if someone's child is experiencing like needle phobia, but otherwise they're not experiencing a lot of anxiety, that's a great opportunity to address that needle phobia, but also keep an eye out for any propensity towards more generalized anxiety, and dealing with that head on before it reaches a crisis point. All right, finally, and I'm sorry, this is going a little long, so I'll try to speed up, but building a workflow for screening procedures. So this could be its own whole talk, but I'll just kind of run through really quickly some considerations if you're thinking about screening, and I'd be delighted to talk offline about efforts we're making to implement screening right now through this ABP roadmap project or otherwise. So the first thing is really thinking about how ready are you and your teammates at your site to implement mental health screening? First of all, what are the barriers, and what are the areas where you're not ready to implement this? And there's actually a readiness checklist that's available on the ABP Roadmap website that can help you think through this in a really systematic way. Next is, selecting screeners based on local needs and resources. Susan mentioned the PHQ-9, which is an outstanding, well-validated measure that can be administered. It's typically considered to be validated most in adolescents and up, and a lot of JDM patients are younger, and so at some sites, other measures might either supplement PHQ-9, or depending on, again, your bandwidth for administering screeners, like maybe take the place of it. So the Pediatric Symptom Checklist 17, for example, can identify depression, anxiety, as well as other types of disorders like ADHD um, for patients as young as 4 or 5 via parent report. And then there's a self-report version for somewhat older children and adolescents as well. And there are other screeners. There's GAD-7, which is for generalized anxiety. There's SCARED, which is an anxiety screener for multiple anxiety disorders of childhood. Once you've got your screeners selected, and you have a sense of what you want to be doing, training staff and having clear roles for who does what, who hands out or who administers the screener, who interprets the scores, who's in charge of dealing with emergencies or urgencies, who provides referrals and for what resources, et cetera. And having a clear-cut screening algorithm with clear actions so that providers know if there's X score or X finding, then there should be Y action taken, as well as when to activate emergency safety planning with the help of your social worker or other providers. And then using EMR-based tools to document screening results and actions taken. So I love the presentation that Susan just gave on the dashboard, and one could imagine so many ways in which screening could slot very nicely into that, the PHQ-9 and other screeners. For those who don't yet have the bandwidth to take on such an effort, there's easy ways like using dot phrases to document screening results and actions taken. Here's one example from our colleague Alana Goldstein-Lever at Nationwide Children's, where this dot phrase just shows the mental health screeners that were administered. So the PHQ 8, excuse me. And you can imagine having the GAD-7 for anxiety here as well. And then there's a scoring range, so it's easy to tell what the score of the patient means, excuse me. And then there's a slot here for interventions or actions taken, per the algorithm that's developed. And then they also actually were doing suicidality screening, so they have that screener, the ASQ here as well. So there are different ways to do this. I also want to give a huge shout out to Susan Chenoy and the whole team at Seattle Children's. They have this wonderful publication I suggest you take a look at, and I'm still kind of revisiting it because there's a lot to learn here about actually having embedded behavioral health in a JM clinic setting. So really having well integrated, not only screening, but co-located, psychosocial support. And there are folks at other sites. I believe that it would be accurate to say, Jessica Tournier's team at University of Michigan is doing similar type of work. This is a great model for really bringing this into your practice, though it can require a bit of logistical work to make it happen. Last, before kind of closing out, I did want to highlight CureJM resources that are available. So if you go to just curejm.org/support, you'll see on the left-hand side this mental and emotional health tab. And if you click that, there's a lot of different resources that come up for parents and patients. So some of those include like information on signs of depression in children and teens, resources aimed directly at child, adolescent, and young adult patients, as well as state-by-state resources, depending on where you're practicing or where your patient is coming from. I love that there are parent and sibling resources as well, given the sort of ripple effect that living with this condition can have. And there are these really cool links to these SIB shops that are specifically meant to provide psychosocial support to siblings of youth with chronic illness, including JM. Some of the resources are divided by newly diagnosed versus experienced caregivers, which I think is a really wonderful way to think about this. There's a module on pain resources, and then CureJam peer and family support groups as well. And again, this could be kind of its own talk entirely, but thought it's important to be aware of some of these resources. And then there are also resources for providers. So I have the URL for that on the right-hand side and just a quick screenshot so you can get a flavor for some of the information and resources that you can access through the CureJM website if you want to learn more. So just to kind of wind down, emotional distress is common throughout the JM disease course. Mental health needs remain typically unaddressed for most families, and patients and families want us, pediatric rheumatologists, to address these needs. There are strategies available within and beyond our community to increase recognition and referral for mental health care for JM patients. And remembering that, although this might sound like a lot of work, just having those empathic conversations, that is an intervention. Collating resources, that's an intervention. And yes, screening is also an intervention. And then keep your eye out for additional mental health trainings via CureJM, CARE, and ACR. And thanks to way more people than I could fit on one slide. But yeah, And thank you also for tuning in today. So.